My name is Alia Qureshi, and I am a general and minimally invasive surgeon at Beth Health and Harvard Medical School. And I would like to thank the program chairs, Dr. Matthew Goldblatt and Lena Kaitan, for allowing me to speak here today, as well as Dr. Rebecca Peterson, session chair, for giving me this opportunity to speak to you. The title of my talk is Barrett's What's Hot and What's Not? Barrett's Biomarkers. Are we there yet? To give you a brief outline of the talk, I'll speak about the rationale for biomarkers, in particular as it pertains to Barrett's. I'd also like to leave you with some ideas about the conceptual shifts in Barrett's research that is ongoing and evolving. We will also touch base on the specifics in the areas of study, including the genetic and genomic molecular research that is ongoing, as well as its limitations. And then I hope to leave you with some more innovative approaches to solving the Barrett's biomarker question. So, what's the need to develop Barrett's biomarkers? The need is that esophageal adenocarcinoma has a 5-year survival rate of 10 to 18%. Survival is dismal, and incidence has increased 600% over the past 3 decades. Barrett's is the only known precursor. So how can we separate and determine those people that will progress to Barrett's esophagus from those who will not? That remains to be the big question, especially when you take into context that unlike original thinking, where we had initially thought that up to 10% of patients with Barrett's esophagus would progress, we now know, due to detailed genomic data, molecular data, as well as observing outcomes, we know that the vast majority of patients will not progress. In fact, only 0.5 to 1% of patients with Barrett's will actually progress to esophageal adenocarcinoma. So how can we sift out? How can we separate the patients that will not progress from those who actually will? We used to think of Barrett's esophagus as very analogous to colon cancer, and this is perhaps a decade ago. We know now, with the ongoing genomics and much richer detailed data, that very few of the patients will actually progress to esophageal adenocarcinoma. This poses considerable challenges to those doing research, as well as to the clinicians looking after patients with Barrett's. Right now, everybody with Barrett's gets surveillance every 2-3 years with multiple biopsies. But there has been a recent shift in thinking, and that is centered around the idea of linear progression of Barrett's esophagus to esophageal carcinoma. And again, those ideas have evolved around the idea that Barrett's is not perhaps so straightforward, not such a linear progression to esophageal adenocarcinoma. And this is actually taken from a figure in Dr. Brian Reed's paper. He's a gastroenterologist in Seattle, and where he demonstrated linear progression, where the original thinking was linear progression of Barrett's esophagus. The more new ideology is that Barrett's has branched evolution, that there are points of where if a certain mutation occurs, then that particular patient will progress in a much more rapid fashion. The challenge that poses to gastroenterologists and surgeons who look after patients with Barrett's is that you cannot identify those who will progress from those who will not progress. And you can imagine the challenge that is, because those patients that have mutations that are stochastic events or large genomic rearrangements or chromosomal losses, those patients have a mutation that will make them progress very quickly to esophageal adenocarcinoma, as opposed to having a long window to observe as we do in colon cancer. So that is really kind of the crux of the issue, to sift out those patients that we can identify easily from those who will progress from those who will not. So what is the role of a biomarker? An ideal biomarker is one that is easily accessed. It reflects the burden of disease, and that is most also sensitive and specific. The ideal biomarker will also allow us to guide our therapy and to help facilitate appropriate interventions for the appropriate individual. In Barrett's, there are at least 4 reasons to develop a biomarker. Identify those patients from those who are going to progress, from those who are not going to progress, the ability to rapidly diagnose dysplasia in a specimen, to detect and predict the response of interventions, as just mentioned, and to identify those at low risk and those patients who will not need surveillance as invasive endoscopy as they continue on in their treatments. The current gold standard for Barrett's biomarkers is histology, to look at pathological specimen after endoscopic biopsy. The other three large areas or categories of biomarkers are genomic alterations, epigenetic markers, and expression and protein markers. And I will touch on each of these. So as I mentioned, the current gold standard is really histologic analysis of biopsy specimen. And that is the gold standard. Here's a pathologic slide stained with PAS. That is the dark blue. And that is the pathognomonic finding of goblet cells. Those large globs of dark blue are those goblet cells. So you would think it is pretty straightforward. However, it's not quite that simple. First of all, the histologic analysis lacks the detail and insight into who will progress and who will not. It's more of a binary demonstration of who has it or who doesn't. Secondly, recent evidence has shown that there's significant inter-observer error amongst experts even. And this is concerning when you consider the implications of low-grade versus high-grade dysplasia, meaning those who will have intervention or radiofrequency ablation and those who will not. Up to half of patients with low-grade dysplasia are misdiagnosed. And that is a significant issue right now in Barrett's management. Genomic alterations are another large area, and these can be broken down into aneuploidy, specific chromosomal alterations, loss of heterozygosity as biomarkers, mutational load, and focal alterations, as well as epigenetic markers. So what does all of this mean? I used to have a slide for each of this, but it was much too long a talk, so I can very briefly explain. Aneuploidy is basically having an abnormal number of chromosomes. Specific chromosomal alterations, loss of heterozygosity is loss of genes, as well as associated areas around genes. A mutational load refers to numbers of mutations, and then you can basically add up all of those mutations and define a mutational burden. And finally, focal alterations are when you look at a genome map and look at specific sites on a genome map, you look to see where alterations occur that also correlate with Barrett, having developed Barrett's esophagus. Finally, epigenetic markers are genes or RNA that are silenced with methylation, so alkyl groups, and this leads to silencing of genes. And when this happens, then these genes are not expressed. So these are all the different ways that people are looking at Barrett's and trying to see where there's a correlation with patients who will progress, and looking at esophageal adenocarcinoma as well and comparing that to Barrett's. And when you do this, unfortunately, none of these are sensitive or specific to Barrett's. Additionally, these are very resource heavy and require significant efforts and to actually use this type of technology in looking at samples. So this is clearly not prime time at this moment. The second big area of research that I'll talk to you about is the use of expression and protein markers. So using cyclin Z1 immunohistochemistry, which is a cell cycle protein, and they looked at correlation between Barrett's and esophageal adenocarcinoma, or Barrett's on its progression, and did find some interesting associations, but neither were sensitive or specific. Similarly, P53 mutations, we know P53 is a tumor suppressor in many cancers, and they did find some evidence of P53 immunohistochemistry in Barrett's and in the progression of Barrett's also, but again, this was not sensitive or specific. Finally, telomere length. So telomeres are repetitive DNA on the ends of chromosomes, and they are shortened in Barrett's, but they are also shortened in many other pathological states. So again, not sensitive or specific to Barrett's and its progression. So all of these different technologies are very cutting edge, and each of these could be a talk on their own, and I don't have the time or opportunity to discuss them with you in detail. Suffice to say that they have not yet demonstrated specificity to be able to be used in Barrett's esophagus. However, the cytosponge technique is an evolving area of growth. It is the idea and brainchild of Dr. Rebecca Fitzgerald in the UK. She developed this sponge that a patient swallows this capsule, and in the acid environment of the stomach, the capsule is dissolved, and it generates this sponge. The sponge has a thread hooked to it. The patient basically just pulls the thread out and pulls the sponge as it scrapes along the esophagus, presumably binding to all of the abnormal and normal proteins, and then that sponge is assayed looking for abnormal proteins that may be on a assay or an array of potential Barrett's biomarkers. And so this is a very simple approach. What I like most about this is it obviates the need for endoscopic surveillance. So I think this is something that's indeed very interesting, and I think we're going to hear a lot more about it as time goes on. The last area of research that I'll be focusing on is glycoproteins and phosphoproteomics. So a lot of people have done some work looking at leptins, which are glycoproteins, and these are covalently bonded to polypeptides or protein segments. And they've looked to see if there's an expression pattern specific to Barrett's. There's been some interesting work in this area, but unfortunately there are at this time, no key signatures that are sensitive or specific. Lastly, I will talk to you about an area that I am working on using advanced phosphoproteomics, and this uses molecular technology, looking at the entire map of proteins within a cell. This is work that I am doing at Beth Israel-Lahey with Dr. Richard Cummings and Dr. Andrew Neely at Boston University. I have an MD PhD student who's very happy and smiling here, Jared Moore, who is working on this along with his research partner, Ryan Heckman. And the idea is basically taking endoscopic biopsies and from patients who are having endoscopy and they are appropriately enrolled in an IRB approved protocol. We then take those biopsies to go to the pathologist for verification of Barrett's. Two are actually then prepared into fragments and then run into the mass spec. And here are some of the data that we're in the process of publishing. These are heat maps on the left demonstrating abnormal Barrett's as well as normal tissue. Barrett's has its own signature, and on the right are volcano plots, again demonstrating variable expression between Barrett's and normal tissue. So we're very excited about this research. We're in the process of writing it up, and I look forward to presenting it to you at a future session. The whole goal of all of this biomarker work for Barrett's is really to generate a kind of oncotype to help us guide and help us separate patients who will need surveillance and endoscopy from the majority of those who will not, or also to help us guide therapy for patients who will benefit from ablation or other therapies, separating those out from those who will not. So with that, I hope that I have given you a flavor of the Barrett's biomarkers in this limited time. I hope that I've given you an idea about the conceptual changes in Barrett's research and evolution of Barrett's. We've talked about specific areas, although I will say quite superficially, with regards to genetic and molecular aberrations that are associated with Barrett's esophagus, as well as their limitations and widespread use. We've also spoken of a couple of the novel approaches that are available, but there is still much more work to be done, and I thank you for allowing me to present here to you today.